personalized relief. If you are joining us, you are in the right place. Once again, you are joining us for Managing Joint Pain, Finding Personalized Relief. Today's event is brought to you by the Cleveland Clinic in partnership with the Arthritis Foundation, and we are very excited to start today's event. A little bit of some notes prior to beginning with our presenters. We want to allow, we have a very large attendance coming in, a large group of people coming in. We want to make sure we give everybody some time. So please grab your coffee, your tea, your lunch, whatever, enjoy from the comfort of home. It is going to be a wonderful presentation. Just a few notes, as wonderful as it is to join from home and the advances of technology, we know that it can be cumbersome and frustrating. So please know the best way to tune into today's event is going to be through Google Chrome or Firefox, and you want to ensure that it is the most updated browser. So if you're having any issues, please know we do have a team behind the scenes that's going to be fielding any kind of issues. We're not seeing anything come up right now, but if you yourself are experiencing any kind of audio or visual issues, please go ahead and log out and log back in using either Google Chrome or Firefox. Once again, you are joining us for Managing Joint Pain, Finding Personalized Relief. And I'd like to take just a moment to introduce myself. My name is Deanna Makota. I'm a marketing associate here with the Cleveland Clinic and your host for today, which means I have the pleasure of introducing our presenters as well as moderating our Q&A segment. So we will save that for the conclusion of our presentation, so stay tuned for that. We have just a fantastic event. To give you a brief overview, we are going to start with the Advances in Knee Replacement by Dr. Kolczun, followed by Nutrition for Joint Pain, which is going to be from our dietitian, Kate Patton, and then again, followed by live Q&A. I would like to call attention the chat function that you're going to be able to find on the right side of your screen. This is going to offer you some really helpful Cleveland Clinic articles and resources, along with any kind of appointment scheduling resources, and a place for you to pose your questions. Many of you did submit questions upon registration, but I just want to highlight that this is a place that if something comes up during the presentation and you want to get it out there, you can send it, and our team's going to take a look and get to many of those questions during the later segment. In addition, we have some wonderful handouts that are going to be available. And as I had mentioned, today's event is in partnership with the Arthritis Foundation. So in the handout section, you will find a little bit more information about the Arthritis Foundation. We are proud to partner with them once again for another fantastic virtual event. But just a quick note on the Arthritis Foundation, in case you are unfamiliar. This organization offers many different resources and support to you or your loved one. Their support includes something that can be as small as just understanding your insurance coverage or connecting you to people who are struggling with the same kind of joint pain that you are. In addition to many local and national events like the Walk to Cure Arthritis, locally here in Cleveland, that's going to be happening this fall. So there is just so many more resources. I can't even begin to name them, but just know that if you have any questions, you want to learn more about the Arthritis Foundation, you can email them at helpline@arthritis.org. for some more personalized solutions. All right, it is the time to just go ahead and introduce our first presenter, and I'm so excited. I'd like to introduce you to Dr. Michael Kolczun. Dr. Kolczun is a total joint and sports surgeon here at the Cleveland Clinic. Now, he joined the Cleveland Clinic in 1999, but he's been practicing in the Lorain community since 1973, when he and his father formed Kolczun and Kolczun Orthopedics. He's a member of the American Academy of Orthopedic Surgeons, the Lorain County Medical Society, Ohio State Medical Association, and the American Orthopedic Society for Sports Medicine. Dr. Kolczun is a frequent lecturer and is the author of A Coach's Desk Reference to Athletes' Injuries, which is a reference for area coaches. Dr. Kolczun, that is quite the impressive bio. We are very excited to have you here with us.
Well, thank you, Deanne. All right, what I hope to do today is to talk to you somewhat about knee replacements and the various kinds of knee replacements. And if it brings up some questions you might have about hip replacements, much of this will carry over to hips also. So we'll talk a bit about total knee replacements, newer popular partial knee replacements. We'll talk about outpatient surgery, and then talk a bit about the newer concepts in pain management, and then finally a little bit about robots in knee surgery. The problem that we have in 2023 is that a good problem. Our life expectancy is increasing, and our seniors are expecting to be active in their retirement years. And all of this goes to compromising some of the longevity of knee replacements, hip replacements. As you see there, total knee replacements are a very common operation for orthopedic surgeons, and there's well over 600,000 knee replacements done in the United States a year. How we'll approach this subject is we'll talk about what arthritis is. We'll talk about when you should consider what type of treatment, whether it's non-surgical treatment, and certainly give you indications to consider surgical treatments. And then we'll talk at the end about some of the advancements and how you should be able to relate to your surgeon. Remember, what we're talking about is your knees. So when we talk about what type of arthritis, there are many different types, well over 100 different types of arthritis, but the common ones are osteoarthritis, which is sometimes referred to as degenerative or wear and tear arthritis, and then rheumatoid arthritis, and then post-traumatic arthritis, arthritis after a knee injury or a fracture through the knee, etc. What arthritis is, in the simplest of terms, is simply loss of the smooth, low-friction surface, the cushion, so to speak, that you were born with. And it's replaced by a rough, high-friction surface. Think of it as a cobblestone appearance, or as a roughened surface that looks like it ought to hurt. The knee is often referred to as a hinge joint. And if you look at this, we see a knee that has very smooth surfaces, and we can understand how they would be low friction, much like a door hinge that's new looks like it swings easily and has no resistance. With arthritis, as the knee loses that cushion and we're down to bone on bone and this cobblestone appearance, that's equivalent to a hinge that's become rusty and out of place and moves very slowly with a lot of friction. So joint replacement is simply removing these rough surfaces and replacing the rough surfaces with a smooth, low friction surface, much like, again, you were born with. There are two types of replacements in general about the knee. One is a total knee replacement, which replaces all three compartments of the knee, and a partial knee replacement, which has been popularized in the last 10 years, and that replaces one compartment in the knee and leaves two natural compartments. And we'll get into talking about what your doctor thinks about these and how he chooses between, and then remembering that they're your knees. So when do you consider surgery on your knee? Well, when all the help that you can get from medical treatment is not giving you the relief that you need. And there's a litany of different things that are tried, from modification of activities and rest to analgesic pain medications, steroid injections, physical therapy, unloader braces, injections with cortisone and lubricants, and all of these traditional things should in some way or another be tried by either your orthopedic surgeon or your family doctor to try to relieve you of the discomfort that you're having without surgery. But when all of these fail, then surgery is a definite option to get you back to, so you're no longer missing out on fun with your family or eroding the quality of your life. Get your activities of daily living back to what you would prefer. Now, the choices that you have in joint replacements, is there something that can be done other than a total joint or a partial replacement? Yes. Osteotomies is a term your doctor might mention. These are done less frequently today than they were in the past. And we'll go through, that's where we cut the bone and realign the leg. Arthroscopic surgery certainly has a place in early on arthritis, and then the partial knee and the traditional total knee replacement. Arthroscopic surgery simply cleans out the worn portions of the joint. Oftentimes you'll be having continued pain, giving way, recurrent swelling, and in a very early on case where we x-ray your knee and we see good joint spaces maintained, that might be an option. We can wash out the joint, debride the joint, take out some of the excessive joint lining, and if you have torn menisci from arthritis, we can correct that. The resurfacing procedures are a total knee, as you see on the left, and that is a prosthesis that's put in for a complex arthritic knee, versus a unicompartmental knee on the right, which shows the prosthesis on the thigh bone is metal, that on the tibia or leg bone is plastic, but you see that the joint space on the outside compartment is well maintained. So you might say, is total knee the only answer? And there's a new way of looking at things. The gold standard, of course, is total knee replacement. What we're going to try to do is say, are there other treatments that match the results we're getting with total knee replacements? So there's two different ways to approach the knee. One, the traditional approach is just to continue as on the left, the knee as a whole, versus on the right, we showed that there are actually three compartments in the knee. There's the medial or the inside compartment, the lateral or the outside compartment, and the kneecap compartment, the patellofemoral compartment. This slide shows that obviously arthritis starts most frequently in the 80% range on the inside or the medial compartment. 15% of the time, arthritis will start on the lateral compartment, and the least common, 5% of the time, is the patellofemoral compartment. All three of those compartments can be replaced. So we showed that arthritis is a segmental procedure or segmental condition, and the segmental solution for that segmental disease could be partial knee replacement. So here it shows that obviously, since arthritis is most frequent on the inside or medial compartment, we have done many more medial compartments than the others, but we've done lateral compartments and patellofemoral compartments, all with about equal success. When we talk about why partial knee replacements are being considered, if total knees are the gold standard, it's because in principle, the smallest operation that we can do to make a patient better is always going to be the best operation, as long as it doesn't burn any other options. So the benefits of partial knee over total knee, it's bit more natural feeling. You have more feedback because there's more of you left behind. Smaller incision, commonly done outpatient, less blood loss, less morbidity, quicker recovery. So I would generally say that whatever a total knee patient does at 3 months, a partial knee replacement does at 3 weeks. But partial knee replacement does not mean partial pain relief, but rather if we pick the right patient, I think you'll get equal, possibly better pain relief from a partial knee than a total knee. Also the importance of complications, because everything in life is risk reward. So of all the wonderful things we can do with surgery, there are risks. Interestingly, the risks for total knee versus partial knee are very similar. The difference is in their incidence, and the chance of complication with a partial knee is 1/2 to 1/3 that of that complication with a total knee. So here we have a bone on bone on the left slide on the inside compartment, and you see that it's been replaced, just the medial compartment, and the outside compartment remains as full as it did on pre-surgery. The lateral compartment is also commonly replaced, and you can see in that case you get knock-kneed, and oftentimes you have buckling and giving way and the feeling that you're going to fall, and that can be replaced with a partial knee to straighten out the leg. Again, notice that the space on the inside of the medial compartment is equal preoperatively as it was after the surgery. And then, of course, the kneecap compartment can be replaced successfully likewise. The prosthesis that we use for the medial side is an Oxford mobile bearing prosthesis. It's one of the only mobile bearing prostheses. By mobile bearing, I mean that white plastic component, the bearing in between, moves front to back, so it is mobile. On the top, the curved stainless steel implant goes into the femur and is cemented into place. The flatter steel component on the bottom goes into the tibia, and it likewise is cemented. The bearing itself is then snapped into place, and as you flex and extend your knee, it moves front to back, and this lessens the wear qualities of this particular prosthesis. It happens to be the most common partial knee prosthesis used throughout the world. So if the doctor you're seeing doesn't do partial knees and tells you they don't work, well, here are the statistics. 98% of partial knees last 10 years. 94% last 15 years, 92% last 20 years, and 87% last 30 years. So the Oxford mobile bearing partial has a survival rate that equals that of a total knee. Post-operatively, there is a partial knee on the inside compartment. You do get back to activities. I wouldn't say take this kind of activity up, but this gentleman had skied all his life and was fairly good at it before and after surgery. It allows you to get back to doing things with your partner. This young fellow was 87, and within the few months of surgery went to Europe to ski, and I quote his statement often. He said, "I want to die young at a very old age." I think we'll all agree with that. This young lady is back to skiing, and she said she's 78 with my partial knee. The following year, she sent me a picture saying that she was just fine, at 79 after both partial knees. So when we consider and compare unicompartmental to or partial knee to total knees, the procedure causes a bit less pain, no blood transfusions, shorter recovery time. Motion is good to better, and generally it feels more natural than a total knee. Not to say that some total knees don't do quite well. So when do we choose a total knee? Well, you can see that we've done total knees, and certainly over a longer period of time, because it's only been in the last 15 to 20 years that partial knees have become popular. But I do total knees approximately 45% of the time in my practice. That means 55% of the time we're doing partials. You do a total knee for severe deformity, and you can realign the leg. There's no place for a partial knee in this knee. Rheumatoid arthritis being an inflammatory arthritis with consequences to the bone, likewise, we do a total knee. And the total knee replacement considers all three compartments. Who is a candidate for a total knee? Generally speaking, it's when other things have failed. It's when the pain that you're having is globally around your knee, that when you are sitting, you still have pain. You get up, you have more pain, but it's the entire knee. And of course, as I mentioned before, rheumatoid arthritis. The time of a total knee has come down considerably. So it's in the time frame of an hour to an hour and 15 minutes. You're out of bed the same day. If you're in hospital, it's overnight and go home the next day. We're doing total knees as outpatients, meaning you sleep in your own bed that night. And you're generally discharged directly home. You have to qualify to be able to go to a skilled nursing unit post-operatively, and simply having your knee replaced isn't always enough qualification. You have to have medical conditions along with it. So it's important for you to realize that it's your choice when it comes to knee replacement, because what we're talking about is your knee. So you'll have choices here. You have a choice between a partial knee and a total knee sometimes. If you're only having pain on one compartment, or always on the inside, or it's just on the outside, you never have pain on the inside, and you're told that you need a total knee, well, it's fair enough for you to question, why doesn't the partial work for me? Understand that 85% of orthopedic surgeons only do total knees. That means that there's 15% of us that do total knees and partial knees. So you won't know that going in, but if your doctor says always that you need a total knee, make sure it's not because he doesn't do partials. The second thing to consider is cemented versus bone ingrowth knees. That's less of a patient decision, but it's certainly something that you ought to understand. Traditionally, in the past, hips and knees were always cemented. Now, hips are rarely cemented. They're press fit. And we have a choice with knees to either cement them or do bone ingrowth prostheses, where the bone actually grows into pores on the metal and fixes the metal to the bone in that fashion. There are criteria for that. But the doctor, your surgeon, should be able to explain to you which way he prefers going. And on the other stance, sometimes you don't know how much osteoporosis you're going to run into until you're into the knee, and the decision can be made at the time of surgery. When it comes to considering the third option that's in your choice, outpatient versus inpatient. Outpatient means you sleep in your own bed that night, and it can be outpatient surgery at a freestanding surgery center that is an orthopedic surgery center, or it can be at a hospital. Inpatient means you come in the morning, you have your surgery, you stay at least overnight, and usually these choices the doctor can make ahead of time, and it has to do with your size. That means your weight. It has to do with how healthy you are. In general, healthy patients with a sick knee can be considered for outpatient surgery. You need to have somebody at home with you that evening to at least help you along if you choose, but it's certainly a nice way of doing it, because there's nothing like being at home, nothing like sleeping in your own bed. Now we're going to talk about some of the advances, and again, we've already talked about partial knee versus total knee, and cement versus ingrowth and outpatient. We have today enhanced pre and post-op techniques that we didn't have 5 or 6 years ago. We have medications today that we didn't have 6 or 7 years ago. The outpatient replacement, as I said before, by definition means you're sleeping in your own bed that night. And again, healthy patients with a sick knee generally would qualify for that. In my practice, partial knees, 70% go home the same day. Total knees, 25% go home the same day, and that number is growing. Age, interestingly, is not a stopper. It depends on how healthy you are, not how many years you've been around. The pre and post-op management is very important with any of this. The medical clearance is something that we've always done, and it's fairly typical whether you're going to have the operation done at a surgery center as an outpatient or whether you're going to have it done as an inpatient. We want to be safe no matter what. I would emphasize that outpatient surgery is done identically. There's no tricks to it, that you have it done as an inpatient. The important thing, though, here is education. The important thing is to make sure that you are aware ahead of time of everything that's going to happen, what door you go into at the facility, and what nurses you're going to see, and what are they going to do, and what can they expect. And then likewise, preoperatively, we give you education as to how it's going to be immediately after your surgery, and if you're going home, what are the criteria that you have to meet to go home? If you're going into the hospital, what are the criteria at the hospital? We hydrate you preoperatively. We found that that makes you much quicker in recovery, and we use medications to prevent pain. What we're doing is preemptively treating for pain before it starts, treating for swelling before it starts. The treatment afterwards is we can pretty much tell you with the medications that we're using and with the help of anesthesia that you are not going to have pain after surgery first day or two, okay? So we use a spinal anesthetic that numbs you from the waist down. It happens to be the most safe anesthetic we have. And we use general sedation so you don't necessarily have to hear the mechanics of what we do. We do an adductor canal block with that is put in under ultrasound guidance, and then we use medication that is long-lasting. This is pain medication, much like the dentist uses. The difference is we now have medication that can numb the area of the knee up to 72 hours. So this is medication that's injected into the tissues of your knee while the surgery is going on. Of course, we know that early ambulation prevents blood clots, so we have you up very quickly after surgery. And I would tell you, as an outpatient, you walk about the distance of half a football field and do stairs. You can get up and down out of a chair and not have pain before you go home. We talk about robotics in surgery. Now, this does not mean that there's a robot that comes into the operating room and operates on you, but rather we have robotics that sort of creates a geofence within the knee, and it controls the operation of either a burr or a saw, so that if you're within that geofence perimeter, the surgeon can turn the saw or the burr on, and if he happens to be outside that perimeter, pulling the trigger on the saw or on the burr, it will not allow it to operate. So it's certainly helpful and done commonly. So arthritis is no longer a game changer. We can keep you young for a much longer. More importantly, we can keep you feeling young and keeping up with your family and enjoying your family to a later age. Maintaining your independence, that's important. As we age, we all want to be able to have control of our life and live at home. Not saying to take up skiing on one ski, but it's interesting the things that we can do. So we've talked about this whole idea of arthritis and total knees, and we've covered what arthritis is, when to talk about or think about surgery, what choices are yours because this is your knee that we are operating on, and then the advances that are available. Thank you very much, and I hope you found this interesting.
That was wonderful, Dr. Kolczun. Thank you so much. Very informative, and we appreciate that presentation. Just based on the questions that we've seen coming through, and again, upon registration, I know you've answered many of those questions, but we will be seeing and hearing again from Dr. Kolczun after our next presenter for our combined Q&A. So please, everybody, make sure that you stay tuned for that. And without further ado, Dr. Kolczun is going to go off camera, but he's still going to be with us. And I am so proud and happy to introduce our next presenter, who is Kate Patton. Kate Patton is a Cleveland Clinic sports medicine and preventative cardiology outpatient dietitian. She earned a Bachelor of Science degree from the University of Dayton and a Master's of Education in Exercise Science from Cleveland State. Kate was awarded the Elizabeth L. Schroeder Award of Excellence in 2006, and she later completed her internship here at the Cleveland Clinic and joined the team as a staff member in 2007. Kate is a member of the Collegiate and Professional Sports Dietactics Association and a two-time qualifier and participant in the Boston Marathon, along with 5 additional marathons and numerous half marathons. If that is not impressive enough, Kate is also an adjunct professor at Cleveland State University and the team nutritionist at Baldwin Wallace University. Wow, Kate, that is extremely, extremely impressive. Thank you so much for joining us. Now, have you done any other marathons?
I ran the Cleveland Half this past weekend. I did.
Wow, that's wonderful. Yeah. That is so wonderful. Well, thank you so much for joining us. I know that there is a lot of anticipation for your presentation here on the nutrition component for joint pain. So without further ado, please go ahead.
All right. Thanks for having me. Okay, so objectives for my talk today are to hopefully help you learn how to improve the quality of your diet. So one of the goals is going to be to help you learn how to increase your intake of more nutrient-rich foods, which we know can help lower inflammation, help you optimize your vitamin and mineral intake, and possibly even support weight loss. And we're going to talk about why it's important to decrease your intake of more of the high fat, highly processed foods, because we know these are associated with triggering more inflammation, increasing your risk of chronic disease, and likely supporting weight gain instead. Okay, so the pre-joint replacement nutrition priorities are avoiding malnutrition, supporting a healthy weight. We're going to talk a little bit about the right foods to fight inflammation and why iron-rich foods are important. We'll talk also a little bit about your vitamin D needs and why fiber and fluid are important also prior to possible joint replacement. Okay, so we know that, with osteoarthritis, it's possibly, going to limit your mobility. And if you have limited mobility, that may make it harder to, cook and prepare meals. So if you're eating less than usual, then you could, start to be, losing weight, and possibly even losing muscle mass. And, losing muscle mass and weakness is really, not going to set you up for, positive recovery after potential surgery. So we really want to try to avoid that. So, one of the priorities is going to be is protein. Okay. So we want to, maintain the muscle mass that you have, if not, try to gain some, because as we age, we do start to lose muscle at a faster rate. So yeah, if you're not using it, you lose it. So it's really important though, to make sure that we do get the right nutrition from foods to help at least maintain the muscle that we have, if not build some more. So protein sources come from all types of animal sources. So, chicken and turkey, fish are sources of protein. As far as red meat, we recommend more lean types of beef, pork, veal, or lamb. Protein also would come from any kind of dairy product, milk, yogurt, cheese, also eggs. But there are lots of plant-based protein sources too. So things like beans and lentils, nuts, seeds, tofu, also healthy sources of protein. And on the slide before, I had mentioned skipping meals can often lead to malnutrition. So if that's something you struggle with and, have trouble, cooking your own meals, then meal replacement shakes or just protein shakes are a great replacement to help you get that nutrition you need, especially the protein. So we want you to include protein with all of your meals and your snacks. And a good range would be anywhere between 20 to 40 grams of protein per meal, or about 7 to 15 grams of protein as a snack. So, you can find this out by reading the nutrition facts label, or as just a general visual, if we're talking about animal protein, like any kind of meat, if it's about the size of a deck of cards or about the size of like a woman's palm of her hand, that's equivalent to about 20 grams of protein. Okay, so next we're going to talk about supporting a healthy weight. So for every, 1 pound lost prior to surgery, or just, in general, there tends to be a 4-pound relief on your knees. So I know it was mentioned earlier that, carrying extra weight can, be a risk for possible surgical complications. So, if you're, looking for that better outcome, then really, working on weight loss prior to surgery is going to help make your recovery after surgery a lot easier. So, as we could do a whole presentation on weight loss and how to lose weight. So we don't have enough time for that, but just some basic weight loss tips would be to, try not to drink your calories. So really staying hydrated with more 0-calorie fluids like water or seltzer water, unsweet tea, coffee that's, not too sweet or doesn't have a lot of additives. Milk, does have calories, but it also has a lot of extra nutritional value too, like your protein and your calcium and your vitamin D. So, 1 or 2 cups of milk, preferably the lower fat milk would be better. And even a little bit of juice would be fine too, but make sure it's 100% fruit juice without any extra added sugars. And definitely try to avoid drinking sodas or sugar sweetened drinks like fruit punches, lemonade, sweet teas, sweetened coffee drinks. These again in moderation are absolutely okay, or, maybe adding, a splash of lemonade, to your water if you want a little bit of flavor, but we just don't want to be drinking, hundreds and hundreds of calories from sugar. So you may be familiar with the, USDA MyPlate, but there's a little bit modified version out there too that was developed from the Harvard School of Public Health. And I like this one because it emphasizes a little bit more detail. So you'll see the, vegetable portion is the biggest portion there in green, and encourages, eating more vegetables and getting a good variety. We'll talk a little bit more about that. Eating plenty of different fruits of all different colors too, to help get a lot of great nutritional value. Obviously emphasizes the healthy proteins and choosing, more fish and poultry and plant-based protein sources, also like your beans and nuts, and encourages you to limit your red meat and cheese, and definitely avoiding those higher fat processed meats and highly salted processed meats. It specifies that whole grains are better for you, talks about the fluids like we mentioned. It also emphasizes the healthier fats like olive oil, canola oil, avocado oil, using those as salad dressings, and to possibly, limit your intake of butter and trans fat too. Just some other weight loss tips. We know from research that people who monitor or keep track by journaling, they tend to be more successful at weight loss and even at long-term weight management. So nowadays, you don't necessarily have to have the paper and pen and journal, but there are lots of convenient apps out there. Certain ones are like MyFitnessPal, Lose It, Noom. A lot of them have free versions. Some have, the more advanced features that you may have to pay for. And even tracking exercise, can be really motivating, whether you have a special watch or pedometer to really help you keep an eye on how many steps you're taking. That the more you move, the more that's going to help with the weight loss too. A few other tips would be to keep an eye on your meal pattern. And as I mentioned before, we got to avoid skipping meals to prevent the malnutrition and to help you, meet your overall nutrition needs. If we're skipping meals, that it can, disrupt your metabolism and sometimes lead to more cravings or cause you to be more hungry later in the day and then overeat. So a more consistent eating pattern is better for most adults. And try to prioritize meal planning also. So, being prepared is likely going to help you prevent, dining out, whether it's fast food or even, going to the vending machine. So I always try to recommend patients, grocery shop regularly and have their refrigerators and pantries stocked with, the quick, convenient go-to foods. And also, consider a little bit of menu planning each week. So you do have some plans is when we're, you're going to set yourself up for success if you have some plans and have things defrosted and know what you're going to eat. And also consider being a little bit more mindful of just your eating behaviors. If you're eating fast or you're distracted while you're eating, you often end up eating more or making less healthy choices too. So think about, actually sitting down, turning off all your electronics, putting your fork down between bites, chewing thoroughly. And also, use the hunger scale to maybe question whether you're actually hungry before you maybe grab a snack. Some people also, if you're not drinking enough, tend to mistake thirst and hunger. And, if you're not hydrated, you may think you're hungry, but you're actually thirsty. Okay, so next we're going to move on to anti-inflammatory eating. So this too, could be a whole presentation on its own, but I tried to kind of condense this information, and I apologize if I go through it too fast, but I'll try to touch on all the important points. But basically, anti-inflammatory eating is an eating pattern that can promote and improve your immune system. And hopefully is going to limit, the foods that can make inflammation worse. So it's not exactly a diet, but more of an eating pattern. So one of the core foundations of an anti-inflammatory diet is really eating more plant-based foods. So we want to eat these plant-based foods because they're rich in phytonutrients. And these are substances that are made by plants that we know provide health benefits. So there's been, plenty of research on the benefits of fruits and vegetables, beans, grains, any kind of plant-based food. You may not know there are actually up to 4,000 phytonutrients out there, but only a small handful have actually been studied. So you may have heard of beta-carotene, lycopene, gluten, anthocyanins, resveratrol, and isoflavone. So these are those phytonutrients that we find in a lot of different fruits and vegetables and plant-based foods. And the key to get enough of these and enough variety is really is color. So, each week trying to shop for, a variety of different colorful plant-based foods. So definitely first starting with fruits. So we know fruits provide fiber and fluid, vitamins, minerals, and as well as lots of different phytonutrients. So, beta-carotene is going to be found more in your orange fruits like cantaloupe, and lutein is in your citrus fruits. Lycopene found in watermelon and grapefruit. And those anthocyanins, those are found in the berries and cherries, as well as then the flavonols are found in apples and grapes. Vegetables, right? Most Americans don't eat enough of these, but we really, really should, because they are super, super foods, which are full of fiber and vitamins like vitamin A, B, C. And you may not realize that, vitamins do have a lot of minerals, especially even calcium. It's not found in just dairy, but dark green leafy lettuce is a source of calcium, and even spinach is going to be a source of iron for our bodies. And magnesium is also found in spinach. Potassium found in a lot of different fruits and vegetables. And then we know phytonutrients found, so abundantly in so many different vegetables. You may have heard about nightshade vegetables, which include the eggplant, tomato, peppers, and potato. So there is some thought that these particular vegetables may kind of exacerbate arthritis symptoms, but there really tends to be limited evidence. So my recommendation would be, if you feel like these are triggers for you, then you can try eliminating them from your diet for 2 weeks to see if they improve your symptoms. But if you really don't notice a big difference, then there's no need to, eliminate these, since they do offer other vitamin and mineral and antioxidant benefits. So legumes, that's a term that describes things like beans, like black beans, pinto beans, kidney beans, lentils, split peas. So these are what we call more plant-based protein sources. So we want to try to, encourage patients to cut back on their animal protein intake and consider replacing with the plant-based protein. So not only will you get, protein without a lot of fat, but you'll also get plenty of fiber, especially soluble fiber, which is the type of fiber that helps lower cholesterol. Soluble fiber helps really with improving inflammation and lowering blood sugars too. And it's going to be a great source of lots of B vitamins, plenty of minerals. Nuts are another source of healthy plant-based protein, great source of fiber, and they're a really rich source of unsaturated fats like your mono and polyunsaturated fats. I would encourage you to try to go for those unsalted versions, since, most of us, need to watch our salt intake. So all nuts, have a great variety of different types of fats, but we know almonds, walnuts, and hazelnuts do have some, positive benefits on lowering risk of cardiovascular disease and lowering inflammation and helping you get those omega-3 fats from the walnuts. But I would encourage you to be mindful of their portion size, since they have so much healthy fat. Fat has more calories per gram, making nuts a little bit more calorie dense. Okay, extra virgin olive oil is a rich source of monounsaturated fat. And extra virgin means that it comes from the very first pressing of olives. Therefore, you get the richest amount of those antioxidants. So I encourage patients to use extra virgin olive oil as a salad dressing or possibly as a dip. but to try not to cook with. And instead, you can get olive oil that comes from the later pressings of olives that you can cook with at more of a moderate type of heat. Or avocado oil has a higher smoke point to cook with, or even canola oil. Omega-3 fats, these are a particular type of polyunsaturated fat that we know from, lots and lots of research that they have anti-inflammatory benefits. So in our diet, we can get these omega-3 fats from especially wild-caught fish like salmon, tuna, sardines, certain types of trout, and herring. So a typical recommendation is about 2 to 3 servings a week and about 3 to 4 ounces per serving. So certain types of nuts and seeds have a plant-based source of omega-3 fats that, our body can convert, to a small extent into the other types of omega-3 fats that come from fish. So nuts, though, will still, walnuts in particular, will still offer some anti-inflammatory benefits, along with the flax seeds and chia seeds, which have the healthy fat, a little bit of protein, and fiber too. Okay, so grains, we really encourage patients to choose whole grains. So grains being things like wheat, rye, oats, barley, any form of like rice or quinoa. We know that whole grains, are kept intact, and therefore you get more nutritional value. In particularly, you get more fiber, and the type of fiber that's found in grains has been shown to lower markers of inflammation in your blood, known as C-reactive protein. And those grains are going to offer more B vitamins, potassium, and magnesium. Okay, so poultry we know is, just a little bit better for us since it doesn't have as much animal fat in it, but so good quality protein. And, be sure to choose choose poultry that's baked, broiled, or grilled. And, try to avoid the breaded poultry, try to avoid the skin and fried poultry just to avoid all those extra fat calories. Now, red meat, though, certain types of red meat, can be much, much higher in fat. And really processed. So we want to try to avoid that. But red meat in moderation is absolutely okay. So 1 or 2 times a week, choosing a lean type of beef or pork is absolutely acceptable. So when it comes to dairy, so cow's milk and yogurt are a source of good nutrition that has carbohydrate, protein, fat, calcium, vitamin D, potassium. So really, really nutrient dense. Source of calories for you. But nowadays, a lot of people might have, lactose intolerance, or there's so many other non-dairy alternatives that, the dairy aisle can be quite overwhelming. So again, if you don't have any issue with lactose, then, cow's milk and yogurt are going to be a really nutrient dense option for you. I would recommend more of the lower or non-fat options just to minimize the extra fat calories. Just keep in mind the non-dairy options like soy and almond and pea protein, they all have a different amount of carb and protein and fat, but they all do tend to be fortified with calcium and vitamin D. So regardless, those are all still good options to have daily. Just keep in mind that the certain nutrients do differ. Okay, so just going to highlight a couple more categories of foods that we do need to limit. And that would be saturated fat, refined grains, added sugars, and alcohol. So saturated fat is the type of fat that comes mostly from animal sources. And we know that when it's in excess, it does tend to be more pro-inflammatory, does tend to raise our bad cholesterol, and just doesn't set up, our body for, the best health. So sources of saturated fat tend to be red meat, especially processed meats, cheese, full fat milk, butter, and typically desserts since they're made with butter and milk and often egg yolks. we talked about the benefit of those whole grains. So we want to be sure to avoid, though, the refined grains. These are the type of grains that have that outer grain removed. So then you're losing that fiber, losing a lot of nutritional value. And this type of grain then does digest a lot faster, which raises your blood sugar faster, can, just increase some, stress hormones if your blood sugar is, not very consistent, and in turn then be a little bit more pro-inflammatory. And often refined grains have even extra, sugar added too, as just a flavor enhancer and preservative. So try to avoid the, white breads and white rice or white pastas or refined, grains like cereals and crackers or instant potatoes or instant fries. Try to, choose those foods like a whole potato or, foods in their natural source, like oats, things like that. Okay, so there is room for, some sugar in our diet. That's the good news. But we know that, in excess, that too much sugar really does tend to contribute to inflammation and higher blood sugar levels and obesity. So the good news is, though, is that it is safe to have up to 6 teaspoons of added sugar per day. So you can obviously measure this by, if you're the type that uses real table sugar or honey, or you can monitor this by reading the nutrition facts label under total carbohydrate. It'll list fiber, the natural sugar, and then any added sugar. So for women, up to 24 grams then of added sugar per day. So for an individual food, I would try to choose foods with no more than about like 4 to 5 grams of added sugar. And men can have up to 9 teaspoons or 36 grams a day. So, comparing that though to like those sugar sweetened drinks, a can of soda, 12-ounce can often has around, 50 grams of sugar. So not a lot of room to drink those sugar sweetened drinks. And then alcohol, we know that it can have some health benefits. So, drinking 1 drink per day for women or up to 2 drinks per day for men, can have some health benefits. But we know that drinking more than that then does tend to have negative health effects, especially weakening your liver function. Okay, so next, moving on to choosing iron-rich foods. The reason we want you to do this is because it can reduce your risk of anemia after surgery. So best sources of iron do come from those lean red meats. So remember, it is okay to have some red meat. So things like pork tenderloin or a center cut pork chop, beef tenderloin, sirloin, flank steak, those are good. Oysters, clams, and eggs, also sources of iron. And then you do get iron from plant-based sources. So your animal sources of iron are the best absorbed, and the plant-based sources aren't as well absorbed. However, we do know that when you pair these plant-based sources of iron with vitamin C rich foods, so like your tomatoes or peppers or citrus or strawberries, that can help. So spinach salad with some tomatoes and strawberries would be, great to, include, even if you're just having chicken for dinner or, if you're having a salad with beans. And this, I apologize, I should say, like fortified cereals are also options for plant-based sources. So vitamin D, you may have heard of how important this vitamin is. I feel like it gets a lot of press nowadays. So we've known all along that it's, really important for our calcium absorption and for our bone health. But I think newer research has really shown how important it is with lowering inflammation and improving our immune health. And the more that, this has been tested in patients, we've become more aware that deficiency is really common. And one of the reasons is that the most absorbable source of vitamin D actually does come from sunlight. So for, a certain population of the United States who, doesn't get a lot of sunlight, then, that's an issue. Or obviously if you work indoors, year round, that can be an issue. So you might want to talk to your primary care doctor about having your levels checked if you've never had it checked, and think about taking a supplement if your numbers are below where they need to be. Okay, so next we're going to talk about fiber and fluid. So again, we've talked about, the benefits of a lot of plant-based foods that are naturally going to give you the fiber. So these two, though, are important, especially after surgery, because you may or likely will be on some type of pain medication, and pain medication can contribute to constipation. So to kind of prevent that and make sure you're in, a good regimen of having good bowel regularity before surgery, try to work on increasing your intake of those fruits and vegetables. Your whole grain foods, we want those to have about 2.5 grams of fiber per serving. Remember, if you're eating those beans and lentils and nuts and seeds, you'll be getting that extra fiber too. And we talked about getting, a lot of good 0-calorie fluids like your water and seltzer water, unsweet tea, coffee. On average, the recommendation would be about 64 ounces per day, or half your body weight in ounces. That's a good goal for total fluid. And remember, milk and juice, broth, anything like that all counts towards your total fluid needs. So remember, key takeaways are to try to avoid malnutrition, and talk to your primary care doctor to maybe take a look at, what your body mass index is at, and see if, it would benefit you from losing weight. And if you need help, hopefully your primary care doctor can, give you some support or, put you in touch with a registered dietitian. And remember to choose those foods that really tend to fight inflammation, which are any type of plant-based food. Make sure you know maybe your iron levels, and consider increasing your intake of those iron-rich foods. Also, make sure your vitamin D levels. This can be helpful just for your overall health, and try to prioritize fiber and fluid, especially after joint replacement surgery.
Great. Thank you so very much, Kate, for your presentation. That was fantastic. I just noticed that as the questions were coming in, you were answering them before we could even get to them. So it was fantastic. But I am excited for everybody to stick around. We're going to be doing a question and answer segment. We're going to have Dr. Kolczun come on back. There he is. And we are going to go ahead and start with some of the questions. Again, many of them were received upon registration, but then some we have been sifting through. So we're going to try to get to as many questions as we can. I'm going to pose them to each of you individually, and we will go from there. So one of the questions, Kate, that I want to ask you first, something that we've been hearing a lot more, and it's kind of a lot frequent. Maybe it's just in the news cycle, but we've been hearing a lot about intermittent fasting. Okay. And so one of the questions that we had is, does intermittent fasting make inflammation worse, or, better, or no effect?
Sure. Good question. So intermittent fasting, it should help inflammation. So what you're doing is you're eating during a shorter window of the day. And then what that means is typically, once we eat in the morning, especially once we have any form of carbohydrate, that triggers our pancreas to secrete the hormone insulin. And so the more insulin we have going, in our body, it can be a little bit more of like a weight gain promoting hormone, especially if you're a little, insulin sensitive or insulin resistant. So, if you're, overweight, trying to lose weight, and you're concerned about kind of inflammation, then I think intermittent fasting is a good strategy to consider. Like an 8-hour eating window and a 16-hour fasting window to try to decrease those insulin levels, which can help help you lose weight, and then in turn, hopefully lower that inflammation.
Excellent. Thank you. Dr. Kolczun, one of the questions that we received is there anything that you could do to stop the advancement of arthritis already in the body?
Well, to tie both talks together, the most common thing you can do is lose weight, because as we've heard, weight loss slows down the wear and tear on our joints. So the one thing that is often overlooked, and is certainly we can all do, is try to lose some weight. I always tell them that every time you lose 10 pounds, you take 100 pounds of force basically off of your joints. And that's an average. I mean, it takes a little bit more off when you're running versus when you're sedentary. So but most of the arthritic patients can't run and take off weight the way they did when they were in their 30s or 40s. So once you hit that magic age of 50, we rely on dieting for weight loss. I suggest intermittent fasting commonly to men because I know well that they're not going to read labels and they're not going to count calories. So the easiest thing to get men to lose weight if they're not a diabetic is with some form of intermittent fasting. Women, it works for women also, but women have always more commonly tried dieting. So they usually have a favorite diet. And whether it's Nutrisystems or whether it's GOLO, which I can't figure out how that works, and any of the other ones, they're out there, and so they're more likely to read and study and follow guidelines. But guys just have to stop eating.
Okay, fair enough. Now, again, kind of tying the two presentations together, one of the questions that we received, Dr. Kolczun, is there a typical BMI that somebody would need to be within before being considered for either a partial or full knee replacement?
Well, there is, but it varies for every surgeon out there. They have their own BMI criteria. So you want to get within the range that your medical doctor says you're healthy. I think that's the best way to look at it. We know that the surgery goes easier and the recovery is faster the closer you are to your ideal weight. And I'm not necessarily suggesting some of the weights that are published, because some of those must be old statistics, because it's much lower than any of us could ever get to. But so it's variable. They ought to talk to their surgeon. Each surgeon has a different criteria. Most surgeons don't want to operate on patients that have a BMI of over 40. And some cut it down much lower than that. So it really depends.
So it would depend. Okay, excellent. Thank you. Kate, one of the questions that we had, you did a really great job of addressing the sugar in diet, but one of the questions that we received are there good or better sugar substitutes that somebody might want to consider?
Sure. Yeah, this is a little bit of a hard or tricky question because there's just been a little bit more, emerging, research recently on, for example, like erythritol and some of its negative health effects. So I really leave it up to the patient. I think, the evidence is a little bit gray, on sugar substitutes versus real sugar. My opinion is I think a little bit of either is safe. So whether you want to use a little bit of real sugar, again, if you stay within those guidelines, I think that's, shouldn't hurt you too much. But if you, really want to try and cut out some of those calories from sugar and use a sugar substitute in moderation, then yeah, sure. There's plant-based ones out there. There's, some that are made from sugar. Just keep in mind that they are a lot sweeter than real sugar. So I always just encourage patients to try to use as little as they need, since we, again, know that typically using them in excess, like drinking lots of diet drinks or lots of, diet products, isn't the best for us either. So I know that doesn't exactly answer the question.
No, the more information we can provide, the better. And I know that folks that are attending are going to really appreciate that. And that's something that certainly comes up quite frequently. Dr. Kolczun, one of the questions that we had received, you did a fantastic job of describing the different options with replacements and how some people can go home and when they can go home. But one of the questions that we received is can a person manage recovery at home from knee replacement if they have no one to help them?
It's more difficult. It depends on their living situation. You know, if they have a one-floor plan, it makes it a bit easier. And if they don't have too many steps to get into their home or their apartment, it's probably, I understand that most people don't necessarily have family that can free themselves up because they're working. However, they usually can find a friend that can look in on them. I don't think anybody has to be with you 24/7, but I think somebody has to be with you the night that you go home to see how you accommodate your home situation. And then after that, it really depends on how comfortable you are. But and if you have somebody that can stay with you a few nights, but do go to work the next day, you should be able to get by. It's a matter, you can pre-cook your meals, that type of thing. So it depends. But if you live in a split level home, tri-level home, you know, when you first go home, you can do stairs, but you can't necessarily do them if you have to run upstairs to go to the bathroom.
And that's fair. Yeah, that's absolutely fair. So it would be certainly dependent on the person.
Right.
Could you, Dr. Kolczun, tell us a little bit more about injections for knee pain, specifically the hyaluronic acid, and your thoughts on that for knee pain relief?
Sure. You know, the two commonly accepted injections are cortisone with lidocaine, or cortisone with a numbing agent. And the other one that's well accepted is hyaluronic acid. The difference is one, the cortisone works by decreasing the sensitivity of the cells in the joint lining that form the fluid, and therefore you don't form quite as much fluid as easily. Which is good, because the problem with a swollen knee is that with arthritis, we form too much fluid trying to protect ourselves. Hyaluronic acid, the difference is it works. I don't, in my practice, it doesn't work as often as the literature says it works, but then again, the literature comes not just from orthopedist offices, it comes from medical doctors' offices, that type of thing. So their criteria for using it may be different. But it does work. I tell patients it works about 50% of the time. It's expensive. So your insurance company makes us get permission from them before we can give you the injection. I think the only insurance that, I hate to say only, but I know if you have plain Medicare, which few people have anymore, you can get an injection anytime. But if you have Medicare with any provider like Anthem or that's providing the Medicare, they put the criteria on it, and therefore we have to get permission to give you a shot if it's going to be paid for. And you don't want to just have the shot and then work it out with them, because those shots are expensive.
Sure.
There are also PRP injections, platelet-rich protein, or I should say platelet-rich plasma, and that's where they draw fluid off of your knee, spin it down, and sort of inject it back into you, the good part of blood that has supposedly some healing qualities. And then, of course, there's stem cells. And PRP may be covered, but I would be careful because those can be expensive. And stem cells generally to inject into the knee to treat arthritis are not covered by insurance. And those will be anywhere from $5,000 to $15,000, depending on where they get the stem cells.
Wow.
So it's I've seen people take a mortgage out on their house to have stem cell injections. So it really depends But all those injections can work. It's just, can you afford to have all of them?
Sure. Yeah, it's definitely better to know beforehand before doing it instead of trying to determine that payment. That is very pricey. Kate, one of the questions that we had, and I know you had touched upon this, was in regards to the best cooking oil. And do you have a preference for avocado or extra virgin olive oil, canola? And one I've never heard of is macadamia oil. I've never even heard of that. So do you have kind of a preference in which you would lean or recommend to someone?
Yeah, a lot of them, depend on just your taste preference and their taste profile and how they, tolerate the heat. So a lot of your like nut and seed based oils, they really don't stand up well to cooking. So I would imagine like macadamia nut oil and walnut oil, are better for just a salad dressing or maybe a marinade, versus I know it's like the coconut oil and avocado oil do have that like higher heat cooking point that you could do like a stir fry. And then something like, just like I said, that middle, like the avocado oil, or excuse me, the olive oil, not the extra virgin, but just traditional olive oil. You can cook at that moderate heat or and whatever you prefer. We know now from a lot of research though that, vegetable oil on its own or corn oil, safflower oil, they have a little bit more of those omega-6 fats. And we know the average American diet has this imbalance of omega-3 to omega-6 fat. And again, there could be a whole nother presentation on that, but the goal is to try to lower our intake of omega-6 fats. So definitely avoiding those vegetable oils and trying to replace it with either, again, those oils that I mentioned, and in general, getting more omega-3 fats helps.
Okay, perfect. Dr. Kolczun, what would you recommend to someone that has already had a hip or knee replacement, but is still dealing with pain in those joints? And my guess is it's probably going to depend on the time frame, but in general, what would you recommend for somebody that's already had a replacement that is still struggling with pain?
Well, obviously, it depends on at what phase they are from their surgery. To have some sort of discomfort for 3 to 6 months after the surgery is not unheard of, but it should be at least tapering off so that you should have less pain as you get further away from the surgery. And eventually we ought to get to a point where joint replacements don't hurt, whether it's knees or hips. The thing that has to be emphasized is you have to plan ahead and get your body in shape to do the things you want to be able to do comfortably. So I tell people, if you, whether it's a knee or a hip, if you like to walk through the woods and walk riverbeds, you can train your knee or hip to do that. And then if you go to New York City and walk 20 blocks, expect to be sore because you're walking on concrete there. And likewise, if you have your surgery and you live in New York City and you train it to walk on concrete, expect you to be sore when you come out and try to walk through the woods and walk riverbeds, because you're using the same muscles in a different fashion. You're lifting your leg more. It's a different surface, a different amount of cushion. So you have to expect that. And, that's something you need to know. How you work up a painful joint? It's a process. You keep, you start off with X-rays and a good thorough examination. And if everything looks perfect on X-ray and there's been no changes, and you're a year out after your surgery, and you say, I've got the same pain that I had before surgery. Well, if it's your knee, you got to start looking at your hip, because maybe you got arthritis of your hip, and it's radiating. We know that hip arthritis can cause knee pain. So there's a number of things that have to be ruled out, and it's not easy. but it's doable, and you just have to have patience, and you have to find an orthopedic surgeon that has equal patience.
Very good. I like that. One of the other questions that we received is kind of before somebody gets a procedure, if let's say somebody's thinking about or starting to consider a knee replacement, partial or full, are there steps, are there any kind of programs that somebody would need to consider, like rehab or physical therapy prior to surgery?
Well, yes, some insurances insist on it. But it really depends on the individual, and it depends on the amount of arthritis they have. For instance, I saw a patient earlier today who has horrible arthritis of his knee, and we put him in to do a total knee on him. So now if I'm doing a total knee on somebody, that means they've got arthritis in more than one compartment. And his insurance didn't approve the surgery because they said he hadn't had 3 months of physical therapy in 1 calendar year. Now, I just said that. I don't understand that attitude, other than the insurance company would rather take money in than pay money out. But the point is that if you put somebody through physical therapy who has horrible arthritis, you're only going to make them worse. Mm-hmm. They're only going to hurt more. Okay, so it's very variable, but we just have to work them up and understand that it is possible, and we can come up with a solution. It just takes time.
Excellent. I'm sensing a theme too with the insurance companies and what someone may or may not be able to do, which is something that everybody should really consider prior to moving forward.
Right. So. Well, I'm not anti-insurance. I'm just saying that every once in a while they do things that aren't. They make rules that are in their benefit rather than in the patient's benefit.
Sure.
And
absolutely.
So if we can get high enough on the food chain within the insurance company and say, look, this is a legitimate person, this is time, hopefully they would listen to that.
Yeah, absolutely. Kate, one of the questions that we had that I'm hoping you could answer is, do you have a recommendation for like a multivitamin that somebody may be able to use? And then I do have a follow-up question for that in regards to vitamin D, but is there just like in general a multivitamin that you may recommend for someone?
Yeah, I think the ones that are age specific are definitely important to choose. I typically encourage patients not to go with the gummy ones because the gummy formulation typically can't have like iron in them and doesn't have like all of the vitamins and minerals like an actual capsule will have. So try to choose that. As far as choosing a good brand, a couple things to look out for on the actual like packaging. Anything with like a USP seal stands for United States Pharmacopoeia. So that's typically, a safe product. But what's tricky is that the U.S. Food and Drug Administration doesn't really regulate and test, the supplement industry very well. So if you really want like a very good, clean, quality product, there are a couple what we call third-party testing agencies. One is NSF and the other one is Informed Choice. So you can kind of look up their websites, and they have what are called certified as safe products, where they test the ingredients to make sure they don't have any banned substances, and the ingredients they say they contain, they really do. And if they make any claims, that's not always the case with like a multivitamin, but if you're looking for other products, different supplements, whether it's like glucosamine and chondroitin or a protein powder, it's safe to choose those tested products.
Excellent. Thank you.
Deanna, can I ask Kate a question?
Sure. Oh, well, of course. I love it.
All right. I have patients who after surgery feel quite tired, and it's past the time that I think they ought to have gotten their energy level back. Understand that after anesthesia of any sort, I tell them that it's not unusual. that you feel pooped out about 3 o'clock in the afternoon, take a nap, and so on. So, but two things. Number one, for the person that is out 6 months or maybe a little bit more than that, and they just haven't gotten their energy back, is there a energy boost diet that you have? And the second question is, does balance of nature work?
So not familiar with any energy boosting diet. I think it would be, the next step would be to kind of just try to rule out other things that might be causing their fatigue, whether it's like sleep apnea or their thyroid, or maybe their eating pattern, is erratic, and they don't have, consistent energy, or maybe they're not getting enough sleep. As far as that, I would just need to I would just work with the patient, one-on-one to see what we could do to improve their energy.
How about these things that we see advertised all the time on TV, like Balance of Nature?
I've never heard of that. What is that?
Well, it's 2 pills. One's pink and one's green. And you take them daily, and they say that you can run and leap tall buildings. And I'm willing to go out and get it. But the question is that there are many of those on the market that say there's nothing proprietary about them. They say it's either one has fruits and one has vegetables in it. And then they came out with one that says has fiber in it. So I understand how the fiber is supposed to work, but I don't understand how the others do, or whether it's just marketing.
Sounds like marketing to me.
Okay.
I love that you asked that you asked her a question. This is fantastic. And I think this is a perfect place for us to wrap up our event today. I want to first and foremost thank both Dr. Kolczun and Kate for joining us today, for offering just a plethora of information and sticking around to answer all of the questions that we had. I'm so happy that I had both of you, and you answered a lot of the questions that we had received even prior to the event in your presentation. So thank you both. I know it is we're so fortunate to have you both here. So thank you. A couple of other steps for those that are in attendance. I want to let you know that probably within the next day, you're going to be receiving an email from Big Marker, and the Cleveland Clinic Big Marker is our hosting site here, that the video that you see today is going to be available for viewing. So it takes, about a day for that video to come through. So please watch out for that. You're welcome to share this video with anybody that you might think would be interested or can benefit from it. I'm sure that there are many pieces of information that you can kind of take with it. Or if you missed something and you want to go back and watch it, you will be certainly able to view that. So watch for that email. In addition, we once again want to draw your attention to the handout section. There is more information on arthritis foundation, as well as the Cleveland Clinic. And again, you'll be able to find some additional resources and helpful articles. So thank you everybody for tuning in. We really appreciate your time today. And we do hope that this event was enjoyable as well as informative. And thank you again to our presenters. And I hope everybody has a wonderful rest of the day.